So before we get started, I want to show y'all something. So if you go on Blackboard and you go to review, there's a lot of stuff on here that's hidden because I can't release it yet. But I did put up here the mid-module review, the one that had all the answers. So if you click here, you'll be able to see the answers, explanations. And then I put up the near-pod matching review, which a lot of students think is really, really, really helpful. So that one has been up since yesterday. I think those are the only two things that are up so far. The rest will get put up on Friday. But somewhere to start if you're like wanting to start reviewing things. I think it's pretty helpful. So this session thought that it would be a good idea as I was reviewing material to maybe go through some things with y'all from kind of a high yield standpoint, but it's not something that I would want to cover with you without having covered all the meat first. So it's definitely like more high yield, but not everything you need to know. So I want to point out that just because I don't cover something today doesn't mean that it's not important. Do we all understand that? Or we're good with that? So that being said, I'm going to open up this packet. This is what we're going to review from. It's Rosh Review has kind of a all-encompassing high-yield packet that they do for all of the modules. And so I pulled out pulmonary system. This is what they think is the most high-yield material of all of Pulm. So I don't have enough time to cover every single lecture from start to finish, but I do have enough time to review the review packet. So that's what we're going to do today. All right, so starting out with COPD. So let's talk about COPD. COPD is one of the obstructive lung diseases. It's in the name, it says obstructive, right? And there are two major categories we need to know the difference between: chronic bronchitis and emphysema. Now we know that in the real world, there's a lot of blending of chronic bronchitis and emphysema, but in test world, they really try to separate the two. And we should know the major differences between emphysema and chronic bronchitis to include the presentation, the blue bloater versus the pink puffer, and the PFT differences. So let's talk about, this is emphysema. Let's talk about emphysema first here. So we know emphysema is a problem with the lung parenchyma. So the airspace, the alveolar walls and things get less elastic. They lose their elasticity and they lose their lung tissue. So you lose area for diffusion of oxygen and carbon dioxide. Usually the patient you're going to see in a vignette, I think is pretty self-explanatory. It's going to be someone who is a little older, who has a smoking history. And the major presentation of emphysema is going to be dyspnea. However, they will also typically throw in the other pink puffer stuff. So large barrel chest, large AP diameter, pursed lip breathing, thin, those kind of things. Oh, right here, physical exam. Pink skin, pursed lip breathing, barrel chest. It's almost like I read that, but I wasn't reading it. And then hyperresonance to percussion because of the air trapping, the chronic air trapping that they get. Diagnostically speaking, if we're looking at the PFTs, we're going to see first off a FEV1 to FVC ratio that's less than 70 usually. That's indicating a more obstructive pattern. We use the FEV1 to determine the severity of the emphysema. They'll also have typically an increased TLC and then also a decreased DLCO in emphysema. Okay, that's not on here, but I could probably include it. I don't think, do I have ability to like text or something? I don't know if I can do that. Let's see. Just trying to figure out. Y'all need to help me with my technological skills. No, I don't know. I can't get it, but decrease DLCO, what I would put there. And then comment. So if you see someone that has the signs and symptoms of emphysema, but they are young and they're not a smoker, you should think alpha-1 antitrypsin deficiency. Okay, that's the major thing for emphysema. Here's the picture of the pink puffer, thin, barrel-chested, large AP diameter, They're getting damaged alveoli, loss of elasticity. They're difficult getting that air out. The recoil's not as good. And then here's some of the clinical findings we've kind of already discussed. Complications. Emphysema tends to get pneumothorax more often than chronic bronchitis, and that is because all these dilated air spaces can form little bullae, and those can rupture and cause pneumothorax. And they have typically, like we said, thin bodies because they're working really hard to get air in and out of their lungs. All right. So moving on, chronic bronchitis is the other. Oh, and it is a kind of a pathologic diagnosis. I mean, the diagnosis is made by the destruction of the tissue. Okay. Going on to chronic bronchitis. Chronic bronchitis is a clinical diagnosis. In the presentation, they're going to give you this somewhere in there. It's going to be, you have to have a chronic productive cough for at least 3 months and at least 2 consecutive years. Okay, that is the diagnostic criteria. Usually these patients appear more overweight and cyanotic, like a blue bloater. On physical exam, they're going to have some decreased breath sounds. They'll have a little bit of increased resonance to percussion, and then they also use accessory muscles to breathe. And their FEV1 to FVC ratio is less than 70%. FEV1 is less than 80% predicted. So again, FEV1 is a good predictor of the severity of their COPD, but they will have a normal DLCO. Okay. And so they look a little bigger, blue bloaters, okay? Smoking cessation. So the management of this on both of them, the management is a little tricky. First and foremost, we need to encourage smoking cessation. That's one of the few things that decreases the morbidity and mortality. And then we usually do a combination of inhaled bronchodilators, inhaled corticosteroids, and inhaled muscarinic medications. Okay. Both of these have the risk of going on to develop cor pulmonale. Just to mention that here, but we'll talk about it separately. How do we feel about COPD? Are we okay with it? Do we understand the major differences between chronic bronchitis and emphysema? Good. All right, here's the one we said was a little trickier. We said infectious stuff was harder. So let's go through it one by one, and then we'll see how we do. Bronchiolitis. To me, when I see bronchiolitis, it's usually, they usually make the patient be an infant to early toddler. So baby usually in the vignette. And they usually present kind of like what I think of as like an asthma, but caused by an infection. So it's affecting the very small airways. We know the major culprit is going to be RSV. RSV is the major virus that causes bronchiolitis. Bronchiolitis is the illness. And we see marked difficulty breathing that can be displayed in a vignette multiple ways. It can show nasal flaring, accessory muscle use, respiratory distress, wheezing is a big one. I don't know if can I highlight it at least? Wheezing. Throughout the airways. Basically, the diagnostic studies, you can get an RSV test that will help determine if it is RSV. But major diagnosis is made by physical exam, so history and physical. In the textbook world, most care is supportive in nature. However, you do need to know that if they're 3 months or less, you need to admit them to the hospital. If they're anywhere in the single-digit months, you need to be careful. You need to look at the signs and symptoms. Notice if they're having increased work of breathing, if they're hypoxic, then those are the ones we need to admit to the hospital for care. Let's see. The treatment that is not bronchodilators. You can give it. You can give a trial of it, but that's not the major care. The major treatment is supportive care from a textbook standpoint. Okay. Do we understand what that looks like in a vignette? I think we've seen quite a few vignettes of bronchiolitis. It's a virus, so don't choose an antibiotic. And you can try these other things, but most of the time the question will ask you what treatments, and it'll be supportive care, or you'll need to know that you need to admit the kid to the hospital. Okay. Acute bronchitis. Bronchitis is of the bigger airways, the bronchi, and usually it's caused by viruses. That's the number one cause. And this is different from chronic bronchitis. This is the acute bronchitis caused by an infection. So I bet all of us have probably had this at some point. You get this cough. Most of the time we can treat symptomatically since it is a virus. Sometimes patients respond well to bronchodilators. And it is the most common cause of minor hemoptysis, meaning a little bit of blood-tinged sputum. This is the most common cause of that. Not cancer, not TB. This is the most common cause. So when you read a vignette, don't automatically assume that because a patient has hemoptysis that it's cancer or TB, because this is more common. So read through it, put the pieces together. Routine antibiotics are not indicated. Okay, so these are all the different etiologies that can cause it. There are a few bacterial ones that can cause it, and in most cases, these will clear on their own even if you didn't give antibiotics. But obviously, if we detect that they have pertussis or mycoplasma or chlamydia, we're going to want to treat it if we know that's what it is. All right. Now, bronchiectasis. It's not really infectious. I'm not sure why it's in the infectious disorders. Bronchiectasis is chronic dilation of the airways, usually due to increased sputum production. Cystic fibrosis, it is the number one cause of bronchiectasis. You can get it from having repeated respiratory tract infections, like associated with cystic fibrosis. And when they describe bronchiectasis, they're going to say that the patient is coughing up cupfuls of pus. Cupfuls of pus, a lot of pus. And they're going to have something else going along with it. Multiple infections caused by cystic fibrosis. They usually have some crackles or wheezing on exam, which is pretty nonspecific. The sputum will often be foul smelling too. And really, really important things that we want to pick up in vignettes are going to be the tram tracks or signet ring signs. We talked about that a little bit. And the best diagnostic test is going to be a high resolution CT. So here are those tram tracks. You can see those thickened dilated airways. Signet ring is going to be when you see them on end, kind of like this one down here. So it's looking at the tube on end. Treatment, well, you got to figure out what the patient has that's putting them at risk for multiple respiratory tract infections. Like we said, cystic fibrosis is number one here. And then you have to treat the infections, keep them hydrated, chest physiotherapy, like that vest, to keep the liquid, to keep the mucus less dense and easier to clear. Okay. Are we doing good so far? Have a long way to go, so let's keep going. Epiglottitis, 3 Ds, dysphagia, drooling, distress. You'll see that in the vignette. Usually they'll mention that the patient, if it's a kid, that they're unvaccinated. Okay, and it's usually rapid onset. The kid looks toxic. They have fever. They're leaning forward in certain positions. They're drooling. They might have some stridor, but it won't mention a barking cough. It might mention muffled voice, or like a hot potato voice. The classic x-ray finding is going to be the thumbprint sign. However, like we've mentioned multiple times, you don't necessarily get the x-ray in all the occasions. And most importantly is airway management. Okay, so not getting the kid super agitated, keep protecting the airway, and then also administering IV antibiotics. Okay. Most common bug, H. flu, although we don't see it as much anymore because we vaccinate against it. All right, laryngotracheitis or laryngotracheobronchitis in some cases is the other fancy word for croup. Croup is caused by parainfluenza virus. Most often can be caused by other things, bacteria and other things, anything that essentially inflames or infects the upper airway, the voice box area. Okay. Most of the time when they talk about croup, they'll mention like a toddler. So usually it says 6 months to 3 years old. Usually You see more of the toddler, like 1 to 3. And they'll almost always mention some sort of barky cough in the vignette. When you see that, you should think this. They have also sometimes stridor. And x-ray, they love to test on this steeple sign, although you don't need x-ray to make the diagnosis. It can be done clinical. The treatments of choice are going to be, if they have very, very mild symptoms, no stridor, just a barky cough from time to time, they don't look sick, then you can treat them just symptomatic care. So just supportive care, humidifiers at home, and things like that. Now, if they come in and they're moderate to severe croup, like they're having some stridor, their oxygen saturations are a little lower, then we need to administer 2 things. First off, dexamethasone. Dexamethasone can be given if they are outpatient or inpatient. It's 1 dose. So you give them a dose and they're good to go. Racemic epi is not like albuterol. You cannot give them a prescription and say, hey, do these racemic epi nebs at home. We don't do that. Racemic epinephrine nebulizers are only done in the acute care setting, so in the ER or when they're admitted to the hospital. And so usually we reserve racemic epi nebs for those that are having more significant trouble breathing, like stridor or hypoxemia. So kind of important. I don't think I would be mean and put both of these on there and say, which one would you do first? But generally speaking, if it's very mild, you can do nothing but supportive care. If it's moderate, you can probably start with the dexamethasone because most kids get that. That's what's going to help them long term. And then the racemic epi helps them in the short term to reduce the inflammation. So we only do that in the acute care setting. Okay, that makes sense? Right. Very good. And the steroid of choice is dexamethasone or Decadron. All right, bacterial tracheitis. I didn't talk about bacterial tracheitis. Dr. Hidalgo did talk about it, and usually it's a little older, 3 to 5 years old. It also has a barking cough, but it's an older kid, and the kid is super toxic appearing. And toxic appearing means that, you know, they're having trouble breathing. They look really ill, like they can't quite keep awake, they're having trouble breathing. They'll mention like toxic appearing or lethargic or things like that in the vignette, and that in that case they need to be admitted, they need to be intubated, and they need to be given IV antibiotics. I see very, very, very little questions on this, but the key factors to differentiate it from croup is that they're much more toxic appearing and it's much more rapidly progressing. So in that case, it's airway management, antibiotics, IV fluids. Okay, I don't see very many on that, so just keep it in the back of your mind. Influenza. I think all of us have had flu, or we've been exposed, or we've had a family member that's had the flu. The flu is usually like, bam, it hits you. You get high fever, get achiness, fatigue, like sore. You can also have like upper respiratory symptoms like sore throat, runny nose, cough, those kind of things. Diagnostic studies, we can make it clinically. We don't need to do testing. Like back in the day, 2009, there was that huge swine flu epidemic. And I mean, we were seeing like boatloads of patients in the ER. We could not keep up with however many patients there were. And so we would just make the clinical judgment. This kid was exposed to the flu, looks like they had the flu, this person had, and we would just give the prescription for Tamiflu. But you can do PCRs, they're really quick, and get back a positive test result. In some cases, if you're past like the 48 to 72 hour threshold, supportive care is indicated. However, if you can catch the patient early enough in the process, we can give Tamiflu or oseltamivir. Symptom onset specific. Usually all the symptoms hit you like at once. So it's like it almost like a train hits you. So I'm pretty liberal. So like if the patient says like I started feeling bad at, you know, in the afternoon, and it's been a couple days and it's already going to be the afternoon, I'll give them the oseltamivir. I'll even give it up to 72 hours after the start. But I'll tell them it might or might not help you at this point. So all the symptoms usually start at once, fever and the other symptoms. Okay, so it is the most common cause of viral pneumonia in adults. RSV is the most common cause of viral pneumonia in kiddos. But just keep an eye out for all these symptoms. They might or might not tell you that the PCR is positive. But look out for this. Look out for like exposure to the flu, unvaccinated against the flu, those things, to try to trigger you to think. They have to make it really obvious that it is the flu so that you know that it is. Whooping cough. We don't see this very often. I've seen it only a couple times. It's going to be in the vignettes, it's going to be the paroxysms. That's usually when we see it. So it's going to be cough, 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 whoop. And usually they also mention some sort of post-tussive emesis, or like those little petechiae that you get around your face. Like if you throw up a lot, if you have a bug, or if you're hungover, you'll sometimes get some broken blood vessels from all the coughing. If you catch it within the first 2 weeks of the illness, this paroxysms, you're supposed to treat it, and we treat with macrolides. I usually use azithromycin. I feel like it works the easiest, the best, but be able to recognize it in a vignette as the rapid fire coughing fits, and then treatment is a macrolide. And usually look for unvaccinated kiddo. Okay, pneumonia is bacterial. So bacterial pneumonia, there's this typical versus atypical presentation. Talking about strep pneumo. Strep pneumo is the most common. Usually they'll describe it as acute onset, typical presentation, plus or minus this rust colored sputum. And they usually get chills and they feel really sick, and it's acute, right? So that's what you'll look for strep. Also, strep pneumoniae, they also have usually a lobar consolidation. Not that other ones can't, but this one specifically really likes to consolidate a certain part of the lung. That is most common. Klebsiella, looking at that, usually in the vignette somewhere they're going to mention alcoholics, current jelly sputum, is what they usually mention for that. Okay. Staph aureus, usually either an IV drug user or post-influenza. That's when we see this most often. H-flu, we're going to see that more in COPD patients. Pseudomonas is for cystic fibrosis. They go hand in hand. Cystic fibrosis, Pseudomonas. And then healthcare associated can be a bunch of different things. It's multi-bug. So Pseudomonas, MRSA, things that you find in the hospital. Management. So if they are healthy and they have community-acquired pneumonia, then we can treat with macrolide or doxycycline typically. There's a really nice slide in my presentation that talks about the treatment. If they're outpatient and they have a comorbidity, like diabetes or other things, or if they've been on antibiotics recently, we want to do a respiratory tract fluoroquinolone. So pretty much anything but Cipro. Usually Levaquin is the one that they recommend. If you're inpatient, I usually recommend, I'm not going to test you on inpatient management, but if you're inpatient, usually they start with a respiratory tract fluoroquinolone. And then for ICU, you're going to have to add on a whole bunch of extra stuff onto there. So it's pretty hardcore. I don't know if you need to know that for pharm, but for my purposes, don't worry about the crazy treatments for ICU and inpatient. Here's a nice little slide, again, just summarizing. If you see questions on pneumonia, they're usually going to be really obvious which type of bug they're asking about, because they have to give you something. They have to. So again, strep pneumo, most common, acute onset, typical presentation. H-flu is COPD usually. Staph can follow influenza, or it can be cavitary lesions, or it can be MRSA related. Klebsiella, alcohol use, aspiration pneumonia, it can cause that. A current jelly sputum, Pseudomonas, chronic lung disease, sometimes mechanical ventilation, but most often cystic fibrosis. Those are the more typical ones. The atypical ones, mycoplasma is going to be close quarters, either a soldier or a college student, someone that's in close quarters with other people, usually more of an atypical presentation. So like like a URI more than anything with the cough, a little bit achy, sometimes sore throat, more like a walking. They don't look quite as bad as the typical presentation. And the treatment is at a macrolide. Legionella, if you see that, it's also atypical. You're going to see something in the vignette that mentions that they were exposed to some sort of humidifier air conditioning system that was contaminated, and they have a lot of extra stuff. So they have the GI side effects, sometimes some neurologic side effects like diarrhea, things. They have hyponatremia. So look for those things in the vignette. They'll kind of stand out like a sore thumb. You're wondering, like, why are they telling me this? It's because they're trying to make you think Legionella. Let's see. The other ones, these don't get tested quite as often, so I wouldn't worry about them as much. If you ever get a question on any of these, it's gonna be something so random on a test that you like either know it or you don't. And I don't know if that's worth like trying to cram it in your memory when you're trying to cram all this other stuff. No, we treat all of them with antibiotics. All of these. If it unless it's like a fungal stuff, then we don't treat with antibiotics. But all of the atypicals we treat with antibiotics. So in most cases, we don't know exactly, if we're clinically speaking, we don't know exactly which bug they have when they present. They come in with signs and symptoms of pneumonia. So we treat empirically. And then from there, we do try to get cultures that will tell us exactly which bug it was, but we treat empirically. And the drugs that we use, the ones that we talked about up here, these drugs should cover the bugs. So here's the more atypical stuff. Mycoplasma, most common again. Also look for this. Do y'all know what bullous meningitis is? Google it. They're like bullae or like blisters on the eardrum. And it looks pretty painful. And if you see that, you should think mycoplasma. It's not 100% mycoplasma that causes it. But if you see that in a vignette or you see that in real life, you should think mycoplasma. All right, again, Legionella is going to be the aerosolized waters, diarrhea, hyponatremia. And then these are some of the more random ones that we don't see as often. Let's see. Dry cough. We already kind of talked about this. The physical exam, I had a question on yesterday about physical exam findings. Like, if you just gave me rails, honestly, it could be a whole bunch of different things. You have to take the physical exam findings and put it together with the historical pieces and other physical exam findings. Like the lung sounds by themselves don't mean a whole lot, except maybe wheezing. Wheezing has a like more narrow differential. Usually asthma or bronchiolitis are more common with wheezing. But here you go. We were asking what management is. Usually we start with macrolide for this. Can add other ones to it like doxy or fluoroquinolone. They all treat. The good thing is that the treatments that we give for atypical and typical, they usually work for both. Okay. The fungal stuff. We all love the fungal stuff. No, we don't, but fungal stuff. So look for the stuff in the vignette that's going to tell you that's what you're looking for. If they say Ohio, Mississippi River Valley, spelunking or cave exploring, bird or bat droppings, you're going to think histoplasmosis. And sometimes they'll have some pulmonary calcification, all sorts of other stuff, but just look for that. This is where the Mississippi and Ohio River valleys are. So cave diving, bats, bird droppings, and they'll have kind of a atypical presentation on lung examination. Okay. Treat with antifungals. I'm not going to test you on whether it's itraconazole or amphotericin B. Okay, that's the one that's tested most often for fungal. That's the one that's highest yield. If we said instead, I'm not sure it's on here. like we said, like Arizona or California, dry heat. What would you think more? Coccidio. Good. What would you think? Those are really the ones we see most often. So bird breeder's lung is more of a occupational disease. So they're like chronically exposed to the lungs. It's like a hyposensitivity pneumonitis, like the farmer's lung. And so you might see it kind of get better and get worse whether they're more exposed or not. And as far as I know, it doesn't usually cause like the same like infectious type presentation. It can be kind of hard to differentiate. They'd have to give you something really specific that differentiated it. All right, PCP. HIV CD count less than 200. Okay. Bat wing, they say it's like a bat wing pattern. So in this area, I've just always seen it as like interstitial on both sides. And just look for that. If they say HIV and they say CD4 count less than 200, and it's kind of this non-productive cough atypical type presentation, think PCP. And it's Bactrim that's the treatment for that. So TMP, trimethoprim sulfamethoxazole. Okay, we already talked about RSV. We said it's common cause of bronchiolitis. It can also cause problems like pneumonia in kiddos. Okay. TB, we learned that pretty early on. I think Dr. A and then Dr. J kind of followed that up. The more important things I want you to remember that these patients usually have some sort of insult to their immune system, immunodeficiency, or they've immigrated, living in close quarters. Those are the kind of like prisons and things. Those are the ones that typically get TB or that have the manifestations of TB. So you can have primary TB. Usually the primary stuff is asymptomatic as well as latent. So really don't usually see anything with that. It says here fever is the most common, but it's pretty nonspecific and they're usually asymptomatic. The one that they usually see tested is the reactivation TB. That's when they have fever, night sweats, weight loss, productive cough, and the cough usually has blood tinged sputum. It says here you can have erythema nodosum. I don't see it very often tested with this because there's other things that can have erythema nodosum, like sarcoidosis. So I wouldn't pay too close attention to that, but it can happen. Chest x-ray wise, for primary, you're going to see lower lobe problems and the GON complex / GON focus, which are the lymph nodes in that area. Okay, that's for primary. For reactivation, which is usually the one they test on, you'll see cavitary lesions in the upper lobes. Okay, and diagnosis. So they say our gold standard for diagnosis, screening especially, is PPD. So we need to know the different PPD classifications, which we'll do right now. And then reactivation, that's for primary. For reactivate or latent, sorry. And then reactivation TB, if they're symptomatic, the gold standard is going to be the 3 acid fast sputum cultures. Okay. Management, they always test on drugs for this. You have to know the drugs. Okay. Ripe therapy. Let's see, PPD. I think I have a slide for this. Here's the ripe therapy. Okay, and you need to know the side effects for each of the drugs. I probably won't test you on that, but I'm guessing Dr. Paz will if she hasn't already. Okay, here's like another kind of at a glance look at how it comes up. This is more of the primary stuff, the GON complex, and then the lymphadenopathy. And reactivation, you're going to see more apical cavitary stuff. Okay. How are we doing so far? We've almost been at it for an hour. We're doing pretty well. Let's see, we're about halfway done. There's a lot to cover, unfortunately. And that's why I don't have time in class to like go over everything over and over again, because that's kind of what I would expect y'all to be doing the meat of your studying by watching my lectures, a lot, reading your materials before you get to class. But it's okay. We're just pointing out the highlights here. So carcinoid, I don't see it tested as much. It is a tumor. It's a neoplasm. It's like in a constellation of neuroendocrine tumors. And so usually with this in the vignette somewhere, they'll talk about flushing, like all this like extra liquid. So flushing, diarrhea, and then they can also have some wheezing. The diagnostic study of choice is the 5-HIAA. I don't see it tested that often. I didn't talk about it that much, but it's something you should be like vaguely familiar with. Lung cancer. So most common type is the adenocarcinoma, which is part of the non-small cell category. And history, smoking is the major risk factor that we have for it. It says the most common presenting symptom is cough, probably a chronic cough. Other things that go along with it related to the lungs, coughing up blood, shortness of breath, some chest pain. And then other things, we know when we have cancer, they usually give us other stuff. So like they'll give us more of the systemic things like weight loss and things like that. They'll also give us like these extra pulmonary symptoms. So Horner's syndrome, we know that's ptosis, anhidrosis, meiosis on the same side. Then there's a lot of Horner's, a lot of it. It's just really easy to test because it's those three things. It's so random, right? They're like three things you don't see very often. When you see them together, you think that, right? Usually indicative of either some sort of central or apical tumor, like a pancreas tumor. Let's see, diagnostic studies. So you can get x-rays. They're not screening tools, and they're not going to be, they could usually see it if you have a cancer, but the best thing to do is to get the CT scan, and the most definitive thing would be a biopsy. I think for the cancers, the best chart to study is the one that I went over in class and on my lecture. I would know that one pretty well. Okay. Screening. You should know about lung cancer screening. You should know who is a candidate for screening. Purple and green. Yes, ma'am. You're right. Screening. We should know who's a candidate. There's a little chart on the screening that you should know. I think it actually comes from Rosh, so we might see it in a sec. Oh, here it is. It says 55 to 74 years. For screening, it's 50 to 80. And for pack your history for screening is 20, greater than 20. And these are just risk factors for cancer. And then we can't have quit in the last 15 years for screening purposes. So don't forget the small cell and squamous cell are centrally located. Also for squamous cell, don't forget that it has the squamous, so we have hypercalcemia. We also have cavitary lesions. Keep going. So solitary pulmonary nodules, when we see them, solitary pulmonary nodules should be less than 3 centimeters. You're going to first compare to previous imaging if you can find it. And then from there, you need to do CT imaging is usually the next step. And then from there, if we think it is cancerous, we need to try to figure out the best way to biopsy it. And it depends where the lesion is located. If it's more peripherally located, we can go do a transthoracic biopsy. If it's more centrally located and we can reach it with bronchoscopy, we usually try to do it with bronchoscopy. All this stuff is going to be managed by a referral, not by us usually, unless we're in pulmonology or critical care. These are just some of the things that help you think whether it's more likely benign or more likely malignant. I had a chart on that in my lecture as well, talking about whether or not the patient's a smoker, how big is the lesion, is it spiculated or not, where is it located, that kind of stuff. All right, lung cancers are very at a glance. If you understand solitary pulmonary nodules and the step-by-step process to figuring out if it's cancer or not, if you know the difference between small cell and the paraneoplastic syndromes, squamous cell, and its problems with parathyroid hormone like secretions and cavitary, if you know that adenocarcinoma is most common and it's more common in women and it is the most common one found in non-smokers and it's more peripherally located, and then large cell is what it is. So I think if you know those basic things, you should be able to pick them out of a vignette. And my questions are not super in-depth on those. You should also know screening based on the chart that I gave you. You should know who qualifies for screening. And what do we do for screening? What is the imaging study of choice for screening? Correct. It's a low dose CT. Very good. All right, let's talk about pleural disease. Pleural disease. Let's talk about pleural effusion first. You have to know the difference between transudative and exudative causes. We'll know that transudative CHF, I'm probably not going to test you on CHF, but you still need to know transudative are going to be CHF, liver cirrhosis, things that are more systemic in nature, low protein. Exudative are going to be more infectious or inflammatory, including malignancy, and PE can be in both categories. The physical exam findings, need to know them. Decreased breath sounds, dullness to percussion, and decreased tactile fremitus. The lung is being moved away from the chest wall. These are really high yield, by the way. Diagnostic studies, we know the typical diagnostic study is a chest x-ray that we start with, and it will show blunting of the costophrenic angle. Okay. How do we manage it? Well, if it is more chronic, like a CHF exacerbation or things like that, we manage the illness that's causing the pleural effusion. If it's like one-sided or we can't figure out exactly what it is, we do thoracentesis for both diagnostic and therapeutic purposes. Lights criteria should be familiar with. Basically what it's saying is, I don't think it has right here. Basically what it's saying is that exudates have more serum protein, they have more serum LDH, and they have an increased LDH in the pleural fluid. Okay, so that's basically what they're saying here. Look for things like that in vignettes. Here's the blunting of the costophrenic angle. We should see the lung fields coming all the way down like this, but these are blunted. You can't really see the bottom of the lungs or the diaphragm. All right, pneumothorax. We talked about these yesterday. Let's talk about spontaneous pneumothorax first. So spontaneous pneumothorax happens spontaneously in young, tall, healthy males usually. And you look for that in the vignette. Look for them to tell you that he's tall and lanky. They might give you the height. They might give you his weight. They might give you his BMI. They're going to tell you that he's tall and lanky. And for, yes, I know, I love my Hotel Transylvania, blah, blah, blah. This is, so physical exam, this is super high yield too. I see him test on this a lot. Decreased breath sounds, decreased fremitus, and hyperresonance to percussion. That is if it's large. You said the number one finding on physical exam would be tachycardia, but I don't see him test that often. I only saw one question on that of all the questions I saw. So on chest x-ray, we'll see an absence of lung markings, and this can be very minimal or it can be really obvious. Like right here, like there is no lung here. This is all black. All that is dead air, no lung. The lung is basically like recoiled down to nothing. And I can imagine this patient would have some pretty significant difficulty breathing. Now it's not a tension pneumothorax because things are not pushing over. The patient probably has some work of breathing, but it's not nearly as bad as a tension pneumothorax. In this one, if I saw this x-ray, this patient needs a tube thoracostomy, period. Yeah. Yes, so not unilateral breathing, but When you put the stethoscope on one side, you'll hear breath sounds. When you put the stethoscope on the collapsed side, you should not hear breath sounds, or they'll be very decreased depending on the size of the pneumothorax. What else? Okay, so management. These are spontaneous pneumothorax. This is primary spontaneous. Okay, primary spontaneous. They're not going to have any comorbidities. They're going to be clinically normal, tall, healthy males. Management wise, for especially for spontaneous pneumothorax, this is a pretty healthy recommendation. So it says less than 20%. I've seen anywhere from less than 10 to 15% here, but this one's pretty liberal at 20%. If that means like 20% of the lung is collapsed, less than 20% of the lung in a healthy patient with no ugly findings, like they're not super hypoxic, they're not super tachypnic, they're not having too bad of work of breathing, then we can recommend observation. Observation meaning we admit them to the hospital, we give them 100% oxygen that helps to re-inflate the lungs, and then we observe them with serial chest x-rays. I've seen quite a few questions asking about this, so I think it's a good thing to know, like if they're healthy, if it's primary spontaneous, even if it's secondary spontaneous, if it's really, really, really small, we don't have to put the chest tube in. We can watch and wait. However, if it's larger than 20%, a chest tube thoracostomy is the method of choice. So it's a chest tube. Okay. One thing I wanted to mention here, because if you've been doing Rosh questions, you probably have gotten a Rosh question on a traumatic spontaneous pneumothorax. So a traumatic pneumothorax can be either spontaneous or it can be tension. So tension pneumothorax are most often caused by trauma, but just a plain old pneumothorax can also be caused by trauma. And that basically it's just a different mechanism. So you have a pneumothorax, but you don't have that valve-like pushing over for a plain old traumatic spontaneous pneumothorax. And in that case, I believe for traumatic, whether or not it's big or small, they recommend putting in the chest tube. So tension, they're going to appear much sicker. So this one's going to say, this vignette for spontaneous pneumothorax, a young healthy male was hanging out with his friends, playing video games, and all of a sudden he had acute onset of right-sided chest pain, or left, whichever, right-sided chest pain, pleuritic in nature, so hurts worse when he takes a deep breath, a little bit of shortness of breath. He presents to the ER. You do an exam. You notice he's a little tachycardic and a little bit tachypnic. You do an exam and you notice a little bit of hyperresonance to percussion in certain areas on one side. You might notice some decreased tactile firmitus or some decreased breath sounds on the same side. And then depending on how bad it is, you get a chest x-ray. That should be the first test that you order in a spontaneous pneumothorax, a chest x-ray. You see the lung collapse on the chest x-ray. If it's greater than 20%, we put in the chest tube. If it's less than 20% and they're healthy and they're not showing signs of any distress, then we can observe, give them 100% oxygen with serial chest x-ray enzymes. That serial chest x-ray administration. So that is primary spontaneous pneumothorax. Okay. Now let's talk about tension pneumothorax, which is next up. Now this patient is going to have been in a bar fight, car accident, stabbed, usually, or we were putting in a central line and we caused it, or they were already intubated and they caused it. And they usually have a history of chest trauma though. And this patient's going to present via ambulance. They're going to be gasping for air. They're going to have decreased or absent sounds on the side. They're going to have tracheal deviation away from the side of the injury. They're also going to have more cardio findings. So hypotension, JDD, they can look almost like they're going into a cardiogenic shock type picture. Okay. And they will definitely make it clear that they are sick. They will have these signs and symptoms on presentation for your vignettes. You don't need any imaging. You make the diagnosis based on the vignette, and the first thing that you do is no decompression, second intercostal space at midclavicular line. Their chest x-ray, we said we don't need the chest x-ray to make the diagnosis, but if they give you a chest x-ray, it's going to look like this. No lung on this side, everything pushed over the opposite side. Everything is deviated. The mediastinum is deviated. The trachea is deviated. This lung's collapsed. There's no breath sounds on this side. Okay. The more it shifts, the more you have the symptoms of the hypertension, tachycardia, the decreased venous return stuff. Okay. And basically, you're sticking the needle in. It acclimates the pressure, and then from there, then you place the tube thoracostomy. All right. So, question: is needle decompression and thoracentesis? No. No. Okay. Thoracentesis. A thoracentesis is going through the back by the ribs, and that is for taking out liquid. Thoracentesis is for liquid on the back. Okay, thoracentesis is not the same thing as needle decompression. That's on the back here in the lower rib area. Okay. The needle decompression is literally you get like an IV catheter with like an 18 gauge needle on it, and you stick it in the chest. It's like what you would see on a movie. They literally get it and they just pss, and you can actually hear the air just pss, coming out. That's for equalizing pressure quickly. The tube thoracostomy is a chest tube that they place in the mid-axillary line in the fifth intercostal space. That's on the same side of the lung. Okay, those are three different things. Sometimes they'll put in a tube thoracostomy when you have like a blunt chest trauma and you have a hemothorax. The hemothorax when you have blood in there, then sometimes they'll do a tube thoracostomy for that and not a paracentesis or thoracentesis, sorry. I've never had to do it. I've seen it done though. You can actually hear the air coming out. Cool. So pneumos throw the axe to the other side. Yeah. Okay, cool. All right, now we're getting to some of the stuff we covered yesterday. So this, I want you to just approach it from a very bird's eye view. You don't need to get super crazy into the weeds with this. It's very straightforward. So cor pulmonale. Cor pulmonale is essentially pulmonary hypertension plus right heart failure caused by a lung problem. Okay. If it's right-sided heart failure and pulmonary hypertension caused by left ventricular hypertrophy or left ventricular failure, it is not cor pulmonale, it's just heart failure. Does that make sense? So usually what starts first is you have some sort of lung disease. COPD is most common. Acute cause would be pulmonary embolism because those come on usually pretty suddenly. We have a lung problem, and basically so in COPD, emphysema or whatever, you have parts of the lung that are not working right. They're not diffusing oxygen very well. They're kind of useless. Our body's sending blood to that area, to the whole lungs, right? And then the body finally realizes I keep sending blood to this one area of the lung or this other area of the lung, and it's not giving me any oxygen. It's kind of sucking at its job. So basically what it does is it clamps down that artery or that arteriole going towards that damaged part of the lung. And it says, you know what? I'm not sending you any more blood. You're not getting me oxygen. But if you have lung disease that's everywhere, then it's clamping down all over the place, trying not to send blood to this damaged parts of the lungs. But eventually you run out of lung that's undamaged. And in the process, you've clamped down on all these little arteries to the point where you've increased the pressure in the pulmonary vascular system, in the arterial system. And so now, because of this, the right side of the heart is trying to push blood against high pressure, which is not used to. It's usually a very low pressure system. And with that, like any other muscle, it gets tired. It wears out. And then we start seeing the signs of backup because the right side of the heart can't keep up. You get right-sided heart failure. So does that make sense? Basically, the things I see most tested most often is COPD being the most common chronic cause of cor pulmonale. I see it's like signs and symptoms of it. So you're going to see the signs and symptoms of COPD plus the signs of right heart failure, which are increased JVD, hepatojugular reflux, and peripheral edema, those things. And then the management or the gold standard is going to be right heart catheterization. Does that make sense? I hope it does. Okay. I try to do kindergarten patho from time to time. All right, let's keep going. So we're pulmonary embolism. We've already covered it in cardio. Now we're talking about pulm. It affects both systems. It's a perfusion problem, right? You can't get the blood to the lungs, not a ventilation problem. So most of the time we get it from lower extremity DVTs, deep vein thromboses, and we already talked about Virchow's triad. Look for in a vignette someone that has a history of long air travel, someone that just recently had surgery, especially lower limb surgery, someone that has cancer, someone that's on oral contraceptives, long bus rides, anything like that. They're going to give you something. And then most common presenting symptom is dyspnea. So having trouble breathing, that's not very specific. You have to add it to the history. And most common physical exam finding is tachypnea. So dyspnea, tachypnea. Here's what I was trying to tell y'all yesterday, and I had trouble, is most common finding on EKG is going to be sinus tachycardia. However, you can see an S1Q3T3, which is also testable. I don't know if it has a picture of it. I don't think it does. Ninja Nerd had a really nice picture of the S1Q3T3. Let's see. X-ray usually shows non-specific abnormalities, but if they're going to test on it, they're going to test on either Hampden's hump, which is basically a little hump of infarcted lung, or a Westermarck sign where you see decreased vasculature in a certain little area. CTPA or CTA is the test of choice, especially when you have in a higher risk probability or higher probability of having PE. You should understand Wells criteria and how to decide whether they require a D-dimer or if you can jump straight to the CTA. Anticoagulation is the treatment of choice. Thrombolytics or embolectomy are what you do in when they're unstable. Like basically they're gonna die unless you do something. And then let's see. A low clinical suspicion, if you don't think it's a PE, you can get a D-dimer. If you don't think it's PE, if you don't think it's a PE, you can get a D-dimer, and if it's negative, it excludes PE. So it's a good rule out test. It's not a good rule in test. So if you think it's what it is, don't order the D-dimer, just order the test. I see there's a picture coming. There we go. That's probably Ninja Nerds, right? S1Q3T3. Perfect. Thank you for including that. Awesome. He does a pretty good job of explaining it. For me, it's really hard to know how much information to give you, because I could talk for days and days and days about all the stuff related to each thing, but we just don't have the time. I have to stop somewhere, and I stopped without including that in there, but I always mention it. So I'm glad that you included that. Here's the Wells criteria. You should definitely be familiar with that. This one is the regular Wells criteria, not the modified. No, not for my class. So question is, do we have to know specific treatment? Like, would we give him low molecular weight heparin or warfarin, blah, blah, blah. So no, not for my class. I would just say anticoagulants. But usually, generally speaking, we would start with a heparin. And then from there, usually a low molecular weight heparin. And then from there, we transition them to either the DACO or the warfarin, which warfarin is not nearly as common as it used to be. But warfarin actually causes hypercoagulability early on, so you can't give it by itself. You have to bridge them over to warfarin. Yeah, sometimes they'll definitely test you on it for the PANCE, but not me. The PANCE will test you on treatment for that, but that's more of a farm thing. But yes, you'll definitely be not by me on my ICM test, but on the PANCE you will be. All right, we already talked about core pulmonale. Pulmonary hypertension can be caused by other things, not just the lungs. It can be caused by heart failure, it can be caused by PAH, it can be caused by PEs, by lung disease, and by miscellaneous stuffs. But in this one, see, this one still includes the 25 at rest. It's actually 20 per your textbook. But either way, that's the diagnosis criteria. It has to be a pulmonary artery pressure of greater than 20 at rest. They don't test too much on this stuff. I wouldn't get too into the weeds on that. Restrictives. So idiopathic pulmonary fibrosis. The most common, most typical patient is going to be a male with a history of smoking. They have the same things that most have, of course, crackles, cough, dyspnea. They can have honeycombing, clubbing, depending on how long they've had it. So they're going to have restrictive characteristics on PFT, which means they're going to have a near normal or normal FEV1 to FVC ratio. You're going to have a decreased TLC. And chest x-rays or CT imaging will show honeycombing, which is like fibrosis around the areas. Honeycombing, yes, restrictive in general, or like, what do you call it? Interstitial lung disease in general. It's not specific to anyone. But if you see a patient that comes in and they don't have any occupational risks that they mention, they don't have anything you can hang your hat on. They've ruled pretty much every specific cause out, and they have this, and they'll have idiopathic pulmonary fibrosis, meaning we don't know what the cause is. It's a diagnosis of exclusion. All right, here's the quick hits. This is about how quick you need to know it. So I would know asbestosis for sure. And I would know where the x-ray findings are for asbestosis. Borreliosis, these are just the people that tend to have it, not as commonly tested. Byssinosis, not as commonly tested. Although one of the students came up to me a few lectures ago and mentioned that her father works in cotton gins, and that especially those of us, not necessarily him, but those of us that maybe have family members that are migrant type workers or that work in cotton facilities, they are at risk for developing this, because they actually harvest the cotton, and they harvest it and they process it in these huge warehouses where there's cotton flying everywhere. And then from there, they ship it to the textile mills, which then make the fabric. So it's like the step before textile. And I had kind of forgotten about that, but she reminded me, so I wanted to mention it. So anyways, you should know these. You should know that asbestosis typically affects the lower bases, like calcified in the bases. Silica usually affects the upper lobes, and then we can also see some eggshell calcifications. Their symptoms are pretty nonspecific. PFTs decreased TLC, and like the x-rays can show kind of a random interstitial fibrosis, and then knowing which ones affect the certain areas is kind of important. So look for that. If they mention it, this is a really nice chart, by the way. I love it. If they mention it, if they mention that they work in a coal mine, take that, like go with it. Okay. They mentioned they were exposed to whatever, like they're telling you on purpose, like pay attention to that. This one's really, really good. So I would definitely know everything that's on this chart right here. Maybe not the talc stuff. That's a little bit more random. And maybe not the cobalt, but for sure, coal dust, beryllium, silica, and asbestos, I would know on this chart. We kind of learned it anyway, but it's a nice chart. Sarcoidosis, super testable. You will have a question on this, like 100%. Usually 30s to 40s African American female. physical exam, you're going to see probably problems with breathing, like dyspnea, maybe some crackles, but then they'll always mention some sort of extra pulmonary manifestation. Lupus pernio, like we said, are those red elevated violaceous plaques on the face. That's pathognomonic for sarcoidosis, and it also determines a more aggressive course. You can also see other things like granulomatous disease in the eyes, uveitis, iritis, erythema nodosum. There's a bunch of things it can. As far as studies are concerned, your chest x-ray is going to be really revealing. It's going to show bilateral hyaluroadenopathy, and if you biopsy that, it's going to show non-caseating granulomas. And on routine laboratory studies, you're going to see hypercalcemia, and you'll also see elevated serum ACE. And the treatment of choice is steroids. Now, there is one question on Rosh that every year trips students up for borreliosis. We said that borreliosis is granulomatous in nature, and so we can treat it with steroids. But if it's mild, actually just do supportive care. That's the question on Rosh. But the question itself, the vignette, doesn't really determine how bad severity is. It just kind of mentions it and then asks what you would do. So I think it's a bad question. But if you come across the question, you'll see a patient with borreliosis that is mild, and you would do supportive care. And then if they get worse, then you would use steroids. Because steroids do have some side effects that are they're not good. So I would not test you like that on my test. I think it's a little hard. All right, sleep apnea. We haven't covered this yet, but I'm going to cover it really briefly. Sleep apnea. I think probably all of us know someone that has sleep apnea. If not, we've heard of it before. Essentially, what happens is we have either an increased neck circumference, we have enlarged soft palate, tonsils, or we're obese. And that causes, I guess, an anatomical defect. The back of our throats, when we're laying flat, everything collapses and we're not able to oxygenate well while we're sleeping. And so as a result, we get pretty excessive daytime sleepiness, snoring. They can actually fall asleep a lot while they're up and around. They'll just kind of fall asleep. At night, there's classic apneic episodes. So not only is their airway kind of getting closed off and they're snoring, they're actually going periods of time where they're not breathing. And that's not good. On physical exam, often you'll see like a bull neck, a thick neck, obese patient with enlarged tonsils or enlarged posterior pharynx area. The test of choice for this is going to be a polysomnography or a sleep study, overnight polysomnography. And the treatment is one risk or lifestyle modifications, including weight loss, propping the head of the bed up a little bit so that you're not lying on your back, all that kind of stuff. But the definitive treatment, or the treatment of choice, I guess, is going to be CPAP. So you get essentially continuous pressure apparatuses. They actually make them pretty small now. They're not as big as they used to be. But basically is giving a continuous supply of pressure back there, which keeps the airway open, keeps patients from having sleep apnea. There's also some other devices that like wake patients up when they're having apneic episodes, which is not a breathing device. It like stimulates them to wake up. But either way, for testing, it's going to be polysomnography and CPAP as the treatment of choice. So these are the kind of things you want to look for in a vignette. And it's bad because over time, it can actually put a lot of pressure on the heart. The heart is not doing well when it's having to go for these apneic episodes, and it can eventually lead to pulmonary hypertension or even cor pulmonale. It's just something we don't think of that often. All right, we're getting close to the end. We have, just so we know, we have ARDS, which we're covering tomorrow, asthma, cystic fibrosis, foreign body aspiration, and a neonatal respiratory. Okay, so let's talk about ARDS. We're going to cover this tomorrow, but essentially ARDS is a syndrome caused by something else. And from a kindergarten patho perspective, basically you have something that inflames the alveolar area, and it causes them to be leaky. So you get a lot of leaky liquid within there. It kind of washes away some of the surfactant, and you basically get this edema bilaterally where the lungs almost completely white out, and it can be really dangerous, life-threatening, very, very bad. Usually sepsis is the cause more often than not that causes ARDS, but other things can cause it, like shock, burns, pancreatitis, aspiration. Other things can cause it, but it doesn't happen on its own. It happens secondary to something else. Basically, on an exam, you're going to see someone gasping for air. They are usually either admitted or they have something else going on, like a sepsis picture, and they can't oxygenate. Even if you give them 100% oxygen, they are not oxygenating. They're like hungry for air. When you do an X-ray, you'll see bilateral infiltrates, basically like whited out like this on both sides, and it's not due to a heart problem like CHF. It's due to this. And it's very, very serious when you see it. We'll cover it more tomorrow, but essentially the treatment is going to be mechanical ventilation, intubation with positive end airway pressure. So you're going to try to keep the alveoli from collapsing every time. Okay, we'll cover it more tomorrow. Basically, you have to treat the underlying condition. If it's sepsis, treat the infection. You're going to intubate, maintain their airway while they're fighting the infection. And a lot of these patients die regardless. It's very fatal if you get to this point. Asthma. So from an asthma standpoint, we understand pathophysiologically that it's airway inflammation, it's hyperresponsiveness, so you get clamping down of the muscles, smooth muscles in the airways, and it is reversible. We can have a variety of presentations. It can be like my kid coughs every time they go outside and they start running. It can be wheezing. It can be every time I smoke a cigarette, I get wheezing. Well, you shouldn't be smoking to begin with, but whatever. You use a peak flow meter to try to assess the normal lung conditions for each patient. If you have a peak flow less than 50% in an acute setting, that's diagnostic of a severe exacerbation. According to the textbook, like I said, I don't see it very often in the real world. Management, that's where it gets a little bit tricky because there are kind of not competing, but two different approaches to management. There's the NAEPP, it's called the ERP4 criteria, and then there's the GINA 2023 criteria. You should be familiar with GINA 2023 because I know Dr. Paz is testing on that. That's what she's teaching. You also need to be familiar with the classification, which is part of the NAEPP. So we need to know the classifications. You should know which constitutes intermittent, persistent, mild, moderate, and severe persistent based on symptomatology. And this is something you could read in a vignette. You do need to know this, okay? Basically, if you have less than two, it's just happening from time to time. That is going to be mild intermittent. If it's greater than two nights, kind of like greater than two, as far as days and nighttime symptoms, 2 per week, 2 per month, más o menos, I would consider that mild persistent. If it's mild persistent, it's going to be daily, greater than 5 per month, and then severe persistent is going to be more than once daily, frequent every night at night. And so you need to be able to classify the asthma. Okay. From a management standpoint, like we're seeing here, we want to maintain an oxygen greater than 88%. The first line treatment for like an acute exacerbation is going to be beta agonists. And then we also a lot of times will tack on an anticholinergic in the real world. In vignettes, I don't always see them mention anticholinergics, but it's good to think about it. And then corticosteroids, we usually give them in an acute exacerbation. Magnesium we would give in severe, like status asthmaticus exacerbations. When to decide whether or not they need to be intubated, it depends on their work of breathing, whether they've been intubated or not before. I think this is kind of a little too in-depth for what we need to know. So let's see, which treatments do Rosh recommend? Let's look. So they're going along with the NAEPP guidelines, or the old stuff. So they're saying to give a beta 2 agonist PRN for mild asthma, and then they're bumping it up to ICS, and then they're bumping the ICS up with the LABA. So if you do a lot of standardized questions, this is the one that they're testing on that I see most often, this right here. Whereas like they start with the SABA and move on. For me, I'm not going to test you on GINA versus NAEPP from a treatment standpoint, because I'm not sure exactly what they're going to test you on for your PANCE exam. So I think you can understand and be aware that there are different approaches. This is kind of the more classic approach. The GINA 2023 has now changed it to basically ICS for Motorol across the board, except when you get into the highest risk. Are we good with that? And there's Samter's triad. Cystic fibrosis, autosomal recessive CTFR gene. Pseudomonas is the most common culprit for infectious problems. They get chronic infections because of the stagnancy of the secretions. They're thick. They lack water, essentially. And let's see, you'll see in a history someone with recurrent respiratory infections, or someone that's not growing like they should. And if they were born here in the United States, should have been tested, genetically tested for that as a newborn screen. But if they come from somewhere else, sometimes they'll slip into the gaps of this. Test of choice is going to be sweat chloride test. I see that is the most common test I see with cystic fibrosis. And that's about all those other stuff that we were taught about. That is very specific stuff, like only specialists manage it. So I would know this from a more bird's eye view perspective for testing purposes. Foreign body aspiration we're covering tomorrow. Kiddos put everything in their mouth, so kids are most common to get this. The way that the airways are, the right side is affected more often than the left because it's a straighter pathway. The left has to kind of turn a corner to make room for the heart. If there's varying degrees of foreign body aspiration, can have someone that has a very small aspiration, can go with just a little bit of kind of coughing and stuff, and there's someone that can include the whole airway, like a choking episode that requires the Heimlich maneuver. So there's different different grades of it, I guess. Most often in vignettes, you'll see a kid, and they'll mention that they were playing with, eating nuts, or playing with this or playing with that, and all of a sudden they have a acute onset of coughing, wheezing, and sometimes like this noisy breathing. And the treatment of choice for this, for foreign body aspiration in a pediatric patient, is going to be a bronchoscopy, where they go in with the camera and they remove it. Usually in kids, it's a rigid bronchoscopy, but I don't think I would get that specific for you. Last but not least, last thing, I'm sure we're ready to be done. IRDS. So it's either called NRDS or IRDS, or it can be called hyaline membrane disease. It's like the old way that we called it. Basically, if you see it in a vignette on this test, so talking about a premature infant, like in those first few hours after they're born, we're talking about this. Okay, that's the only thing from all of the things we're studying in this module that happens at the brand new newborn baby. Okay, so this is basically their lungs go underdeveloped, so they don't have enough surfactant. Surfactant helps decrease surface tension in the alveoli and helps keep those open. So most often you'll see a premature infant in this case, and they usually have it within difficulty breathing within hours after birth. They'll describe it as grunting, chest wall retraction, nasal flaring, and then some of the other more objective physical exam findings like tachypnea, tachycardia, cyanosis. Chest x-ray usually shows decreased lung volume because all those little alveoli haven't had the maturity to open up yet. And they'll have air bronchograms and ground glass appearance. If you see ground glass appearance, think in a brand new newborn baby, think surfactant deficiency, IRDS. And treatment if we know that the mom is going to deliver prematurely and we have time, we can give the mom steroids prenatally to help develop the lungs. If like the mom is in some sort of distress and we're having a feeling like preeclampsia or something, we're thinking she might deliver early, we'll give the steroids. Those that have an increased risk of having a baby with ARDS are going to be diabetic mother, C-section delivery, because when you have a C-section, the baby doesn't get kind of pushed out of the airway. Pushed out of the vaginal canal as forcefully. You don't get that squeezing and get that excess liquid out of the lungs. And after the baby's born, the treatment of choice is, one, we usually do intubation for these babies if they have trouble breathing significantly, and we actually give them exogenous surfactant. So we give them the surfactant usually through the intubation tube, and that helps them. Okay. Right. That was like a super long review. You can see why we always finish class late. We never cover everything. But I hope that it kind of gave y'all an idea. I think for me, it helps me wrap my head around everything I need to know. And then I know what I need to go study. Like, I know I need to go study the chart with all the physical exam findings. I know I need to know my asthma classifications. I know I need to be able to examine PFTs. I know I need to know how to read an acid base. Very basic. So from there, I think you have like your game plan, what you need to know, what you need to study, and then you can tackle it little by little. We have a few days coming up. Tomorrow's lecture is going to be kind of a hodgepodge of different stuff. Friday, we'll do a review, including some Jeopardy. And I will release the end of module exam tomorrow so that you can take a pretest, and we'll review that on Friday. And we have the matching that we can do on Friday. Well, there's a lot we can do from a review standpoint, but you have to meet me halfway. You have to be the one to kind of put that information in your head by spaced repetition, sitting down and memorizing certain things and understanding others. So I'll stick around if anybody has any other questions. I'll be happy to answer if I can. If not, I'll see y'all tomorrow, and I appreciate your participation.